Hello, thanks for coming to today's video. We're going to be looking today at community-acquired pneumonia. So let's go ahead and begin with the definition of community-acquired pneumonia. So pneumonia in general is infection of the lung parenchyma. Now, there's several different ways to classify pneumonia, and currently it's grouped into three broad groups. The first type is a community-acquired pneumonia, where in this situation the patient will get pneumonia from something out in the community or just from being outside. In contrast, there's also hospital-acquired pneumonia, and this is generally with patients who acquire pneumonia while at the hospital. And finally, we have healthcare-associated pneumonia. And healthcare-associated pneumonia is the new one, and that has some specific criteria which we'll go into a little bit. So community-acquired pneumonia is the most common. Again, this is a pneumonia, when a patient just walks into the clinic, they've never had any history of hospitalization or any type of association with some of a nursing home, then it's going to be community-acquired pneumonia. Hospital-acquired pneumonia is generally going to be during or immediately after some hospital stay. And here is also ventilator-associated pneumonia, and these are patients who are intubated. They tend to get a particular type of pneumonia. And what is the importance? Well, the importance is that in hospital-acquired pneumonia, the bacteria tends to be more resistant to certain antibiotics, so they need to be treated differently. Now, the new one is healthcare-associated pneumonia. This happens to patients who are either in nursing home or long-term facility. Also, people who were hospitalized in the acute care hospital for 2 days within the last 90 days. So that's also going to be healthcare associated. Any patients who received IV therapy, wound therapy, or even IV chemotherapy within the last month. And if a patient attended a hospital or he had hemodialysis at a clinic within the last 30 days. So, sorry, with less than 30 days. Okay, so any patient fitting this criteria will be considered healthcare associated rather than community acquired. So very important. And there is a few other ones like immunosuppressed or aspiration pneumonia, but we're just going to use these broad categories. Today we're only going to be looking at community acquired pneumonia, and that's just because generally my videos like to be very thorough, and this is a very big topic, so I'm going to just split up all three topics into different videos. This will probably be the longest of the pneumonia videos because it is the most common and it has a lot of different bugs and everything that we need to go through. So that's what we're going to go over today. So real quickly and briefly, I just want to go over pathogenesis that's kind of relevant. This is kind of a step 2 video, so we're gonna kind of brush over this real quickly. The way that patients generally get the bacteria is through microaspiration. That's the number 1 cause. And so when you do the microaspiration, it either needs to overwhelm the host defense, because you do have different strategies for inhibiting the infection of bacteria in your lungs, and it needs to overwhelm that, or the bacteria is highly virulent, so one or the other. Other causes is going to be hematogenous through the blood, like it happens in sepsis oftentimes. Direct spread, so this could be some type of esophageal disorder or something with the heart, and it just kind of goes over into the lungs. This is very rare. And macroaspiration, this is generally when a patient has decreased gag or a cough reflex, they tend to kind of aspire a large bolus of either regurgitated food or something like that, and then it gets into the lungs, and then that can cause infection. However, these are very rare causes. Microaspiration is your number 1 cause, and that's just something is in the air, you just inhale it and you get the infection. Let's talk about the microbiology. What type of bugs cause pneumonia? It's grouped into 2 main categories. Either you have typical or you have atypical. So what is typical? Typical is going to be a more severe type of pneumonia, whereas atypical would be a less severe type of pneumonia. It's also known as walking pneumonia, and the reason why they call it walking pneumonia is the patient can just be walking around like normal, going to work or doing something like and they don't but they actually have underlying pneumonia. Whereas in typical pneumonia, it's so severe they're not going to be walking around, they're going to go into the hospital. So what is the difference? Well, in typical, generally what you have is you have the bacteria is actually within the alveoli, and it's causing a lot of pus and purulent fluid formation, Whereas in atypical, the bug is not actually in the alveoli, but it's actually invading into the alveolar cells, the epithelial cells. And so it tends to be less severe because you don't have that pus and that purine fluid formation. So that's generally the differences between the two, but we're focusing on it more clinically. So in typical, you also have consolidation, which just means it's kind of contiguous to just one whole lobe or a part of a lobe. And again, like I mentioned earlier, you have mucopurulent sputum, and that's because it's in the alveoli. Whereas in atypical, you get instead of getting one consolidated type of look, you get a patchy or diffuse look, and you have less sputum, much less sputum than in typical. Also in atypical, which really distinguishes it, is you also have extrapulmonary symptoms. And these extrapulmonary symptoms can be something like myalgia, so muscle pain, bradycardia is one. You can also get splenomegaly. Patients also sometimes come with rash, and you can even have CNS problems. So the number one cause of typical pneumonia is strep pneumonia. After that, you have Staph aureus, Klebsiella pneumonia is also one. Pseudomonas is a common atypical bacteria, and you have Haemophilus influenza and Moraxella catarrhalis. So these are the classical bugs that tend to cause a typical form of pneumonia. I'm going to just go over real briefly just some distinguishing features. So strep pneumonia is associated with rusty sputum, whereas Klebsiella is associated with currant jelly sputum, which is a very thick type of sputum. Staph aureus is very commonly associated with influenza. Pseudomonas with bronchiectasis and other type of lung diseases. Now, with atypical, it's broken up into non-zoonotic and zoonotic, and this just means either the bug is, the patient gets the actual bug through an animal or not through an animal. So in non-zoonotic, the patient is not receiving the bug through an animal. There's three of the most common bacterial causes is going to be Mycoplasma. You also have chlamydia, pneumonia, and Legionella. Now, what's interesting about all three of these is these are all intracellular bacteria, and that's why they tend to be atypical, because atypical tends to be bugs that go inside the actual alveolar cells. So keep that in mind. Zoonotic, we have psittacosis, which is you get through birds, Q fever, and we have tularemia. So those are your zoonotic bacteria which cause atypical pneumonia. And what the more common cause of atypical pneumonia are viruses. And this includes influenza virus, which is generally common in patients less than 2 years old or greater than 65, and the pregnant ladies. And this can cause organ disease, CVS, renal, pretty much most of the organ disease as well. So keep that in mind. Patients who have organ disease are more susceptible for influenza virus. You can also get parainfluenza virus can cause atypical pneumonia, and respiratory syncytial virus and adenovirus. So parainfluenza is more common in the immunocompromised, and children and some adults can get RSV. So that's more common. Okay, so let's talk about some risk factors. First, you need to realize that even someone who's healthy with no risk factors can get pneumonia. It's not necessarily a rule that you have to, have some underlying condition. So just remember, it can even occur in someone who's healthy with no issues. This is going to be a pretty long list, so kind of bear with me. It is important that you do know which bugs have which risk factors, so that way you can kind of narrow down what is the actual bacteria. So this is really important for exam purposes and also just in practice. So alcoholism is a risk factor. This is going to be most common associated with strep pneumonia, oral anaerobes, and this is because they tend sometimes to aspirate, and Klebsiella pneumonia and TB. So this is very common in alcoholism. COPD and smoking, again, strep pneumonia is common. Haemophilus influenza. You can also get Pseudomonas. Moraxella is also common in smokers. And then we have Legionella if they're elderly, and chlamydia pneumonia as well. So that's there. So sometimes structural lung diseases can also lead to pneumonia. So again, it's Pseudomonas. We have Staph aureus, and then there's a very rare one, which is Burkholderia apatia. Those can be associated with structural lung disease. Lung abscess, you're thinking MRSA and oral anaerobes. TB, atypical TB, and even funguses can cause lung abscess. So lung abscesses don't normally occur unless there's some underlying immunocompromise. So you can see these are all like TB and fungal will only usually call it common with immunocompromised. MRSA tends to have a necrotizing type of pneumonia which can cause lung abscess, and then oral anaerobes is common with, again, aspiration. Okay, sometimes you can get pneumonia secondary to influenza, and this is common with strep pneumonia, staph aureus. Now, strep pneumonia is more common than staph aureus, but staph aureus is, when you talk about things that can cause staph aureus, influenza number one cause of staph aureus. And then we have H influenza. Next, IV drug abusers. This is going to be, again, Pseudomonas aeruginosa. Anaerobes can lead to that, strep pneumonia and TB, so IV drug abusers. Now, association with farm animals. So people who get in contact with farm animals, one thing you want to think of is Coxiella burnetii, also known as Q fever, which is an atypical pneumonia. Birds, when they're associated with a bird, you're thinking of Chlamydophila psittaci, and if there's poultry, then you want to think of avian flu, which is avian influenza. Rabbits, tularemia. So when you see rabbits, definitely think of tularemia. Bat and bird droppings, if you see that, that's going to be histoplasmosis, and the bacteria is going to be Histoplasma capsulatum. Now, early HIV, you're thinking of strep pneumonia, H influenza, and TB. So that's going to be in early, before this CD count becomes really low. In late, you're going to get more rare type of infection, such as Pneumocystis jirovecii, Cryptococcus, Histoplasma, and Aspergillus. So most of these are only found in patients with HIV, and also the atypical TB, such as Mycobacterium avium complex, Pseudomonas, and H influenza. So, and these are when the CD count's very low. Now, depending on location, you can also get certain bacteria or funguses. In the southwestern U.S., Coccidioides is very common in hantavirus. If someone is from Southeast or East Asia, so this is China, India area, you want to think of like avian influenza, you want to think of SARS, or even Burkholderia pseudomalia. Hotel and cruise ships, commonly risk factor for Legionella, as well as being old and smoking and all these other factors. Bioterrorism. So these are bioterrorism agents, which I guess if there's some type of an attack, you would suggest this. Bacillus anthracis, this would be like someone getting a suspicious envelope. Yersinia pestis, which is the bubonic plague, and also tularemia, which is again with rabbits. So the tularemia is just highly infectious. There are a few more that I just want to go over quickly. Aspiration. So we know that aspiration is when you someone vomits and then inhales their vomit through the trachea. This would be very common with gram-negative pathogens and oral anaerobes. So that's what you want to keep in mind there. Now, patients with endotracheal obstruction, this would be more, you would be expecting some type of anaerobe. Again, strep pneumonia, which is common in most groups, H influenza, and even staph aureus. So most, again, it's going to be, you can see strep pneumonia is a very common trend here. Now, there are some things conditions that can predispose to pneumonia, not necessarily cause anything particular, but just increase the risk of. This is going to be hypoxemia, so low oxygen, acidosis, toxic inhalation can sometimes damage the alveoli, making increased susceptibility to infection, pulmonary embolism, also uremia and malnutrition. These also can lead to increased susceptibility. Patients who have lung cancer, asthma patients, AIDS patients, again, smoking is a huge risk factor. Elderly patients who are over 70, and drugs such as proton pump inhibitors and H2 blockers, not sure why, and even antipsychotics, again, not sure why that's the case. Okay, so those are your basic causes. Before we just move on to how to work up a patient, there are a few fungal causes which you do need to know. Fungal is most common in immunocompromised and neutropenia. So besides these patients, you don't really see it too often. The most common fungal infection is Aspergillus, which is 56% of fungal infections. Cryptococcus is found in the soil. Now, in an immunocompetent patient, it's generally going to be asymptomatic, and you just find it as an incidental finding on X-ray. But however, in an immunocompromised patient, it tends to be very symptomatic. So again, immunocompromised generally has all these. So Histoplasma capsulatum, this is found in the Midwest United States, in the Ohio, Mississippi area. This generally is found in soil where there has been bird or bat droppings. So you want to put all those together. And finally, coccidioidomycosis. This is going to be like the southwestern U.S., where I'm from actually, Arizona, New Mexico, western Texas, central California, Mexico, and then even Central and South America. So that is all the different kind of microbiology causes. So it is important to know which risk factor is associated with which type of bacteria. Common board exam question, and again, even when you're practicing, it can help you narrow down which bug you're looking at. So let's talk about how you would work up a patient who you suspect has pneumonia. Now, the clinical criteria, we are going to go over it, but it's not very sensitive. Only 50% of patients have very, you can diagnose it off of the actual symptoms. So generally, before you can diagnose, you do need to get an X-ray and maybe even try to get some microbiology report, either through sputum culture, blood culture, or through urine antigen test. So keep that in mind as we're going through some of the clinical criteria. So what are the common symptoms? So the most common symptom is a cough, and again, mucopurulent associated with more of a typical bacteria and pathogens, and scanty kind of watery sputum is associated more with atypical. These patients, of course, will have a fever. They can complain of some type of pleuritic chest pain. GIT symptoms consist of nausea, vomiting. You can also get mental status changes, and this is more common with atypical pathogens. Myalgias, rash, and splenomegaly. And again, these are more common with atypical, so keep that in mind when you're working with patients or when you get questions. Now, what kind of signs do you get? Tachycardia can occur, but bradycardia is also possible. Generally, they have a high respiratory rate, greater than 24, and this is actually the most sensitive sign. So, someone with a high respiratory rate, that's what you want to be thinking more likely of pneumonia. On auscultations, you can get audible crackles, and that's just due to the purulent substance that's there. Now, consolidation, you do have signs of consolidation. This consists of dullness of percussion, bronchial breath sounds on auscultation, increased vocal fremitus, and egophony. And egophony is when they say E and it sounds like A. So again, if you do get these symptoms, this is more of a typical pneumonia, not an atypical pneumonia. In lab work, typically you see leukocytosis anywhere between 15 to 30,000 and a leftward shift. You can also get leukopenia, and that's tends to be a worse prognosis. And also anemia is possible, more specifically in mycoplasma, which causes the cold IgM autoimmune condition. So let's talk about X-ray. So what do you find on X-ray? So here we have an X-ray of a patient who has pneumonia. This is going to be lobar pneumonia. Well, actually, sorry, the top one is normal, and the bottom one is lobar. And so what you can see in diagnosing lobar is it's all consolidated. So it's just one entire piece, it's continuous piece of lung, and then the rest of the lung looks normal. So that's generally how you see lobar pneumonia. Now, this is going to be much more different than how an interstitial pneumonia looks like. So this is an interstitial pneumonia, and so what you can see, it's a much more diffuse reticular type of picture. So you just kind of have it in this general area. You have just a diffuse pattern. So you can see the difference here and here. So this is one whole patch, and this is going to be generally everywhere. You can also do a CT scan. That is superior, but it's not used yet. And the reason is because there's no evidence of that. Getting a CT scan improves your outcome. So they don't tend to use a CT scan. Bronchoscopy can also be done, and that's just basically when you put a camera down into the bronchus and you just take a look around what's going on in the lungs. And you can also do a bronchoalveolar lavage, which is when you get a bronchoscopy as well. However, you put in some, you kind of put in some fluid, wash everything out, take all the, and then suck everything out, and with that you take out some of the secretions that's being produced, as well as the cells and bacteria, and then you can take another look, more in-depth look. But in the routine day-to-day basis, X-ray is generally what you do to kind of confirm your diagnosis after the symptoms. Now, after this, you kind of diagnose pneumonia. there's different ways you can determine the pathogen. Now, why do you want to determine the pathogen? Well, the treatment is best when it is pathogen directed. However, the only problem is it's very hard to get a good sample. You generally are not going to be able to actually identify the pathogen because of many difficulties. Getting the actual there's so much bacteria in your mouth and in your esophagus, in your trachea. There's just so much bacteria, normal flora, which can contaminate any sputum sample that you may get, and then blood samples are also have their issues. So we'll go over it one by one. So if you do have an outpatient, you don't necessarily even need to get to identify the pathogen, unless it's one of the what's known as the critical agents. So the critical agents is Legionella, influenza, and the reason why you want to get Legionella is because those tends to be the most severe, more severe type of pneumonias. Influenza because you're trying to monitor whether there's going to be an outbreak in the hospital or in that area. The Middle Eastern respiratory virus, again, that's another one we're trying to watch right now. The spread of these organisms. If it's MRSA, because you do want to know if there's increase in MRSA resistant Staph aureus, and also bioterrorism. So of course you can notify the officials and make sure there's no other attack going on. Severe. So an outpatient not necessarily required. Now, in severe community-acquired pneumonia or patient's ICU, you do need to determine what is the pathogen as best as possible. So there's different types of tests you can do. You can do a sputum culture. You can do a blood culture. You can do a urine antigen test. That's currently only available for Legionella, and that's for serogroup 1, which is about 80% of Legionella, and pneumococcus, so strep pneumonia. You can also do PCR, and PCR will get you about 17 viruses. What's also possible is you can do serology, and so generally a 4 times increase in IgM is diagnostic. You can do an ELISA test and immunofluorescence test. So you have a lot of different tests at your disposal. The serology, ELISA, immunofluorescence, and PCR generally reserved for viruses, whereas the sputum culture, blood culture, and urine antigen test, viruses and even atypicals would be useless for it because it's not in the actual alveoli, it's in the actual cell. So that's why we tend to do this often. There are some biomarkers such as procalcitonin. Generally, if it's less than 0.1 micrograms per deciliter, you don't want to give antibiotics because the chance that it's an actual bacteria is very small. However, if it's greater than 0.25, then you do want to give antibiotics. And so this is one marker that you can use. CRP is also used, and generally if it's greater than 40, it's bacterial. And however, it's less sensitive than procalcitonin, so procalcitonin is used more often. So that's what we have. So let's move on. So let's talk about blood culture real quick. So blood culture is positive 7 to 16% of the time, and in those 2/3 of the time is pneumococcus. So pneumococcus is the easiest one to culture. So therefore, blood cultures are not done routinely. So, but you still should know about it. So what is the kind of pros and cons? Pros is it can establish a diagnosis if it's positive, and it gives you, it gives you resistance data. So then after you culture it, you can go ahead and see if it's which type of bacteria it's sensitive to and which type of bacteria it's resistant to. However, the cons is that it has a very high false positive, and again, that's because you might get some other bacteria that's in the blood that doesn't necessarily come from the lungs, and it doesn't change the way you would treat the patient. So again, that's why it's not done routinely, but it is done if you're going to admit to the ICU. Sputum culture. Generally, what you want to do is you want to do gram stain and culture. When do you do this? Sputum culture, again, ICU admission, you want to do right before that. If you give them antibiotics and it's failed, you might want to try to get a culture so that you can see what it's sensitive to. If they have any type of cavitary lesion, you want to see exactly what bug is doing that. Alcohol abuse is another cause. Lung disease, because you want to see exactly what pathogen, more rare types of pathogens tend to cause that. If the patient has a pleural effusion, or if it's an epidemic pneumonia, so if there's influenza going around, You want to see if this person is within that category, he's outside, and if some symptoms suggest a critical agent, such as the Legionella or the influenza or one of those MERS or SARS or MRSA or something there. Now, when it comes to strep pneumonia and H influenza, these tend to have a higher false negative, and that's just because they have more growth requirements. So it's less likely that they'll grow. So they might be there, but because the growth requirement isn't met, they won't grow, and so then you'll get this false negative. Staph aureus and gram-negative bacteria actually has a high false positive, and that's just because Staph aureus is a normal commensal, so you might grow it, you might think they have it, but actually they don't. Legionella, remember, they require special media, so you need to ask for that especially, and that's the cysteine and iron and all that. Now, when you do get your sputum culture, you do need to make sure that it's a good sputum culture so that you can increase the chance of getting actual bacteria. So what is the definition of a good sputum culture? Well, first of all, it has to be a good cough, and it has to be done before antibiotics are actually prescribed. So it's important that you focus on that. Now, also what you want to do is you want to culture within 24 hours, and if you can't, it needs to be refrigerated at greater than 4 degrees Celsius. Now, in order to consider it culturable, like I guess a sample culturable, you should see greater than 25 neutrophils. So that means you got a good sample, and you see less than squamous epithelium, because that just means you caught a lot of commensals. So if you have any of these, then you can't use the sample. It's pretty much useless. Okay. Besides this, you also have the urinary antigen test. Right now, it's only being used for Legionella and pneumococcus. Now, what are some, I guess, pros and cons again? Pros is it's very sensitive and specific. You can get immediate results, and it's even valid after antibiotic therapy. So that's really good pros right there. However, the negatives is that if there is no bacteremia, then the sensitivity and specificity decreases. So that's another important, so you want to keep that in mind. Also, you can't check for antibiotic sensitivity, of course, because it's not culturable. And if it's positive, that's pretty helpful. But if it's negative, then you probably want to still do a blood and sputum sample. So negatives don't really help you too much. Now, for viruses, what you can do is you can either culture, serology, ELISA, immunofluorescence, and PCR. So those are kind of what you do for viruses. So now what we'll do is we'll just go ahead and discuss about the management. So when you come across a patient where you're suspecting pneumonia, one of the first things you need to decide is whether you need to admit or not, or you can just treat this patient as an outpatient. So oftentimes that can be difficult. So there is 2 criteria that you can use. Either pneumonia severity index, which is also PSI. This is an index which has about 20 factors involved, and it stages the patient 1 through 5. However, as you can imagine, trying to keep track of 20 factors and doing all that, it tends to be a little too difficult to use in a practical way. So pneumonia severity index is not generally used mainstream, but it is there, and a lot of evidence has shown that it's very effective. So it is something you do want to be aware of. The second one is used more commonly is CURB 65. So CURB 65, each letter stands for one of the criteria. So C is for confusion, which is what you want to do with as orientation times 3. So you want to ask them about the time, place, and person. Urea greater than 7 millimoles per liter or 20 milligrams per deciliter. A respiratory rate greater than 30 and a BP of less than 90. And 65 is the age. So older than 65, you want to go ahead and give them 1 point. So each one of these gets 1 point. Now, if they score between a 0 and 1, you can generally treat them as outpatient. If they score 1 to 2, then you kind of just want to use your clinical judgment whether you want to admit them or not, so they could be inpatient or outpatient. And if it's 3, 4, or 5, then you just want to go ahead and admit, and you might want to even consider ICU. So ICU has criteria as well. If they have septic shock requiring vasopressor or mechanical ventilation requirements, then you just go ahead and just admit them to ICU. And if they have any of these three of these minor criteria, you also want to consider admitting them over to ICU. So if they have a respiratory rate of greater than 30, if they have an arterial oxygen pressure over a inspired pressure of less than 250, you want to go ahead and admit them to ICU. If it's multilobular infiltrate, you definitely want to consider ICU. If there's severe confusion or they're becoming hypothermic, if their BUN is greater than 20, or if they have hypotension, leukopenia like we talked about, and thrombocytopenia, these are all, so if they have three of any of these conditions, then you also want to consider ICU. But again, what they generally kind of say with these criteria is you still want to use your clinical judgment. This is just one part of you don't want to just blindly follow these. You do want to use clinical judgment. If they don't meet the criteria, but you still really feel the patient is sick, you still want to go ahead and admit. So keep that in mind. Okay, so your mainstay in treatment is going to be antibiotics. So generally, you want to initiate antibiotic therapy right away. So you have empiric therapy that you do, and you need to start it as soon as possible. So you don't really want to wait for getting the sputums and all that. And you might want to wait to get like some blood culture or sputum culture. But again, if that's going to take too long, then maybe you just want to skip that, depending on whatever your hospital policy is. So the important thing to know is you want to initiate an empiric therapy right away. And then after you get back the results of these culture, then you can do then you can do a pathogen directed if the pathogen is identified. So how do you treat outpatient? So you do have the way the treatment is divided is whether the patient is outpatient or inpatient. So generally outpatients, again, they won't be too severe. You're thinking more along the lines of an atypical, because those are the ones that kind of cause less severe pneumonias. So if the patient is otherwise healthy and has no comorbidities, then you want to do a macrolide, or you can even do a doxycycline, depending on what the situation is. So macrolide, doxycycline you want to use if you're in an area where there's a high strep pneumonia resistance to macrolide, because macrolide resistance is increasing. So if you're working in an area of the world where there's a high resistance, you might just want to go straight to doxycycline. And you cannot give doxycycline if they're pregnant. Now, macrolide is typically used because it's very good against the atypical pneumonia bacteria like Mycoplasma and Legionella. And it works against strep pneumonia, but again, like I mentioned earlier, resistance is increasing. So oftentimes you don't want to, depending on where you are, you might not want to use that as monotherapy. Now, if they do have comorbidities or they've had antibiotics within the past 30 days, then again, you're worried that macrolides won't be enough alone, at least. And so in this case, you want to either consider a fluoroquinolone, such as moxifloxacin or levofloxacin, and or a beta-lactam with a macrolide. So those are your two options there. The beta-lactam you want to use is amoxicillin, cefuroxime, or cefpodoxime. And macrolides, of course, I mentioned earlier, but azithromycin, clarithromycin, or erythromycin, those are your three macrolides you want to choose from. Generally, the fluoroquinolones you want to give for 5 days. And the reason why they use this as a second line is because they were trying to decrease the resistance and the Clostridium difficile that might occur. Now, by the way, you cannot give this to patients who might be suspected with TB, and there's 3 reasons. First of all, fluoroquinolones can delay the diagnosis of TB. It can also increase the TB resistance, and it's associated with poor outcomes. So be careful if you're suspecting TB not to give fluoroquinolones. And also QT prolongation, that's one of the side effects of fluoroquinolones, so keep in mind as well. So then what you want to do is once you get the pathogen, then you can do pathogen-directed therapy. So then whatever sensitivity comes, you go in and switch to that and leave the empiric therapy behind. How long do you want to give it for? Generally, you want to do treatment for 5 days, or if they have 2 to 3 days where they're afebrile and stable, then you can go ahead and give it at that time as well. So this is how you treat outpatient. Now, inpatient, you have the non-ICU admissions and we have ICU admissions. Non-ICU admissions, you pretty much give them like you treat them like an outpatient with comorbidity. So you give them fluoroquinolones and you give them a beta-lactam, an anti-pneumococcal beta-lactam and a macrolide. So generally the ones you can give is cefotaxime, ceftriaxone, or even in intapenem as well. And with fluoroquinolones, it's the same ones, moxifloxacin and levofloxacin. So again, non-ICU admissions, just to make it easy to remember, is the same as the comorbidities. Okay, except actually, sorry, there is one difference. In the beta-lactam, you're kind of using the penicillins, but here you're going to be using cephalosporins, more the third generation here. So that's something to keep in mind. ICU admissions. So patients who go directly to ICU, you're going to use an anti-pneumococcal beta-lactam, and that was the ones we kind of discussed before. But on top of that, you also want to add an azithromycin and a fluoroquinolone. So with ICU admissions, you're adding an azithromycin. It's a simple way to remember that. Now, there are some bacteria which require more specific therapies. So Pseudomonas. In Pseudomonas, you want to use an anti-pseudomonal beta-lactam, and these would be your piperacillin plus tazobactam, cefepime, imipenem, and meropenem. So these are your kind of anti-pseudomonas. And you also want to add on top of that either an aminoglycoside with azithromycin, or you can use an aminoglycoside with the fluoroquinolone. So that's kind of your targets for Pseudomonas. Now, if you have community-acquired MRSA, then just add vancomycin or linezolid to your treatment strategy. So that's how you deal with MRSA. Now, there are some adjuvant therapies that I do just want to mention real quick. The first is going to be glucocorticoids. So many doctors do use glucocorticoids, and the idea is you want to decrease the inflammatory response to the pneumonia. This has about, at best, it has a modest benefit, but more studies are required to see if it's, worth giving. Now, there is the TF pathway inhibitors. This is a drug called tifacogan. Currently, studies don't show any mortality benefit, so that's on hold there. Statins. Now, statins are potential anti-inflammatory drugs. Some studies have been done, but they were flawed, so we don't know yet if that's good. Okay, you definitely want to do vaccination, and you want to do vaccination for influenza, and you want to give the pneumococcal vaccine to prevent from strep pneumonia. And of course, you want them to stop smoking, and this is 100% helpful in all patients. So that's how you treat. Now, what I want to talk about is certain conditions where you treat them and the patient and the pneumonia is not resolving. So what is the definition of not resolving? Generally, if there's no clinical improvement for 3 to 5 days, you would consider this as non-resolving. So they don't have to be completely healthy, but they should just be improving within 3 to 5 days. Now, there is a spectrum of normal, healing. So generally, the tachycardia and the low blood pressure, in 2 days that should heal. The fever, the tachypnea and the hypoxemia, that takes about 3 days to get better. Cough will be there for about 2 weeks, and fatigue will also be there for 2 weeks. And the X-ray takes about 30 days to get better. So when it comes to X-ray, that's not a very good way to see if the patient's improving. And even again, they might be completely better, and you still have a bad X-ray. So keep that in mind. Now, there are some underlying conditions, because this is the normal, right? Now, there are some underlying conditions that will make the will make the recovery process longer. So this can be conditions such as COPD, alcoholics, some type of underlying neurological condition, heart failure, chronic kidney disease, malignancies, of course HIV, and then diabetes, old age, or if it was a very particularly severe pneumonia. So these are just kind of quick things that you want to remember, and it makes sense, right? Why it would take longer with these patients. So besides that, so first of all, you want to take into consideration maybe that they have some underlying conditions. Besides that, if it's non-resolving, you might want to consider that perhaps you're dealing with a resistant bacterial pathogen. And so these would be pathogens. The first one could be like a resistant pneumococcus. So strep pneumonia is becoming more resistant to different types of bacteria. They might be resistant to beta-lactams. They can be resistant to penicillins, and now they're, and then macrolide sometimes in certain areas up to 25% of the strep pneumonia is becoming resistant to that. Now, some things in history that might make you think that you're dealing with a resistant strain is if patients who are associated with daycare or hospitalization within the last few months. Also, if they received prior treatment, then that might mean that the only thing that's left over is the resistant strains, and if they had a previous pneumonia within 1 year. So these patients tend to have more resistant strains, so keep that in mind. Also, besides pneumococcus, there is multi-drug resistance, influenza, Pseudomonas aeruginosa, and even MRSA. And multi-drug resistance, to be called that, you have to be resistant to 3 antibiotics. So this is becoming more common. So you're either dealing with resistant pathogen, you might be dealing with an unusual pathogen as well. So unusual pathogens would be something like TB, and this you think of if it was an old patient, an immigrant, or someone who's HIV positive. Besides that, you could also have an atypical mycobacterium, and this is again most common in COPD and HIV patients. Nocardia, this is common in immunocompromised. Actinomyces israelii, aspergillus, and endemic fungi as well. So nocardia is more nocardia and aspergillus is most common in immunocompromised, whereas actinomyces is very common in aspiration. And then we have the endemic fungi, and this, they'd be immunocompromised, plus they live in a certain area of the United States where they have certain types of fungus. And so you can have an unusual pathogen. And finally, if it's non-resolving, then you might want to take consideration that maybe it's not an infection. So there are certain conditions that are non-infectious which would show up like pneumonia. And this can be something like a neoplastic condition, such as carcinoma tumor of the lungs, bronchoalveolar, kind of has an interstitial type of look, and in lymphoma. So all 3 of these on X-ray, they can mimic a pneumonia. So not only can it be neoplastic, but it can be inflammatory. This would be Wegener's, which can have a nodule, alveolar hemorrhage, and sarcoidosis. So these tend to be mistaken for pneumonia. And then you have drug-induced. So there are some drugs that can cause it. Classically, amiodarone, which is an antiarrhythmic, methotrexate and nitrofurantoin as well, and bleomycin that also tends to affect the lungs. So when you have a patient non-resolving, you do want to kind of keep these in the differentials. And again, just generally for a pneumonia patient, you want to keep these in your differentials. So hope you enjoyed this video and learned a lot. I'll see you in my future videos. Thank you. Have a good day.
Vorbește sau știe să scrii, toate astea în Bronx s-a întâmplat de mult. Și de atunci și până azi a devenit un cult. Se numește hip-hop și ar trebui să știi că totul nu-i decât o joacă de copii.
a filmé sa mère, hein. Oh putain.
Où ça va taper là?
Magnifique. Allez, vas-y, bon. Attends. Vas-y, arrête-toi. Arrête-toi.
It was at this moment Jackson knew. He fucked up.
Arrête d'agiter de suite.
Non mais non, arrête, c'est bon.
Ok, ouais, c'est ce que me disait Cédric. Con quoi celui-là. Putain, mais les gens, on a halluciné.
Ah putain! Stop, stop, stop! Eh, celui-là il est fou là!